So today we're going to be starting with chapter 11. So we're starting our unit 4 outcome 2 now, looking at mental health. Okay, so today's chapter or today's content that we're covering, it's only 3 spreads. So it's not too much. And a lot of it we've actually learned last year. So when we did unit 1 and 2 and we did that whole outcome on mental health and mental disorders, we actually learned a lot about what mental health was last year as well. But obviously we're going to recap it again. So when we look at mental health, before we look at, basically the different characteristics of a mentally healthy person and all that stuff, we need to look at this thing called the mental health continuum. So just like we had a continuum for consciousness, we also have a continuum for mental health. And that continuum is basically a scale that shows you the different states of mental health that a person can experience, similar to the different states of consciousness that a person can experience, okay? So we're going to look at what's the purpose of having that continuum and what does it tell us? Okay, we're also going to look at the different factors that can influence a person's mental health as well. So that's the basis of 11A. So when we look at mental health as a continuum, this is what the continuum looks like. You can see that it's not as long as the consciousness continuum that we looked at in chapter 8, but it's still a continuum, okay? It's got mental health on one extreme, and then you've got mental disorder, also known as mental illness in some resources, on the other extreme. Right in the middle, you've got mental health problem, okay? Mental health problems are kind of in between. They're not as severe as a mental disorder, but they're not exactly the picture of good mental health either, okay? They're right in between. Now, what is the purpose? We're going to learn about each of these ones and what they mean and their definition and their characteristics, but what's the purpose of having this continuum? Just like we had the consciousness continuum in chapter 8 to show us that consciousness is ever changing, it's the same purpose, but we just apply that to mental health, okay? So the concept of mental health as being ever changing, as never being a completely permanent or static thing, okay? It's not like our mental health is always the same. It's not like if I'm happy or if I am feeling stable and not stressed today, that doesn't mean I'm not going to be stressed maybe a week from now, a day from now, or even like half an hour from now, okay? So that's the basic idea of having a mental health continuum, to show us that mental health is an ever changing concept, okay? Just like our consciousness is an ever changing concept, in our lives and throughout our lives, we shift from one state to the other. Some of us, most of us, go from mental health to mental health problem and back. And some of us, in fact, probably a good majority of us at some point will even go to a mental disorder. Okay, mental disorders are common. And mental disorders, as we're going to learn about in chapter 12, can stem from your life events that you go through, okay? And we never really know what's around the corner for any of us. So again, we shift through these different states at one point. What that means is a person who has a mental disorder may not live with a mental disorder for the rest of their life. They might recover and go back to a state of mental health and vice versa, okay? So that's showing you that this continuum, similar to the consciousness continuum, shows us that mental health is ever changing. It's never the same. Okay, so that's the continuum. Now we're going to look at the three kind of states of mental health that we talk about that are on that continuum. Okay, the first one is basically mental health. Then we've got our mental disorder, then we've got, then we've got a mental health problem, and then we've got our mental disorder. Now, mental health in your textbook is very simply defined. In fact, I think the definition in your book is something like a state of emotional and psychological well-being, or something along the lines of that. Look, honestly, we don't ask you guys definitions in the SACs. You guys know this. I'm never going to ask you in the SAC to define mental health. So if you just want to not learn this definition, which one, sorry, this one. If you just don't want to learn that definition because it's too long and you just prefer to stick with a state of emotional and psychological well-being, you can do that. However, the reason that we put this definition in, and this definition is actually from the old Jacaranda textbook that we had. The reason we put this definition in, and the reason that I haven't removed it from the slide, is because if those of you who do health and human, it's actually the same definition, okay? It's a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and can make a contribution to their career. It's the same definition you do in HHD. And I know this year's cohort, last year's cohort, year before, there's a lot of students who do both subjects. So for you guys, this definition is a piece of cake because you've already learned it, okay? However, another reason that I haven't removed this definition is that in this definition, it's more specific. You've got a lot of specific characteristics that are not present in that more vague or more general definition that Ed Roller has provided there. Okay, so that's why I would say that maybe know both of them. If you can't be bothered memorizing this one, then go with the Ed Roller definition, that's fine. But at least be aware that these are the characteristics of a mentally, someone who's got mental health there, okay? An example of someone who's got mental health, and we'll learn more about the characteristics of mentally healthy people in spread 11B, but a characteristic of a person with mental health that we can talk about is that they bounce back from stresses quite quickly, okay? They don't let stresses overcome them. They don't let them consume them, okay? What that means is they actually have something called resilience, okay? And again, if you've done health, you might have come across this term. Okay, in health, we look at it as more of an emotional concept, but in psych, it's obviously a mental health concept. Okay, in the middle, you've got mental health problem. Now, mental health problem is what most of us will experience as we shift from mental health to mental health problem. Okay, mental health problem is basically just a period of low mental health, okay, or poor mental health, or a decline in mental health that hasn't yet met the criteria to be a mental disorder, like a full-blown mental disorder, okay? It's just a period of low mental health in which there are differences or changes in the way you think, the way you feel, or the way you behave. Okay, what does that mean? That means that a person with a mental health problem, maybe they've got like 5 sacks in 1 week and they're stressing out more than usual. This changes the way they think. So maybe they're making silly mistakes. They're making silly errors on practice sacks that they're doing because they're not able to think as clearly. It changes the way they feel because it changes their emotions, okay? So they might be feeling more sad than usual, or might be getting more angry than usual at other people around them. It also changes the way they behave. So if someone asks them for help, or if someone is struggling with something, they might not choose to help that person because they are not in a good mental state themselves, okay? The main difference between a mental health problem and a mental disorder is that a mental health problem, like I said in the previous slide, is less severe, okay? And it usually lasts for a shorter period of time, okay? So a mental health problem might fix itself or recover itself once your heavy sack period is over, okay? Once your week where all the sacks that you were having in 1 week, once that's done, you go back to a state of mental health, okay? So common examples of what can lead to mental health problems are stress from studying for upcoming exams or sacks, okay? Some people, and again, I'm saying some, for some people, they develop a mental health problem when they lose a loved one. For some people, though, losing a loved one or experiencing the death of someone close to you can actually lead to a full-blown mental disorder. Okay, we're going to learn more about this in chapter 12. It really depends on who you are. It depends on your resilience. All these factors can influence whether losing someone you love just causes you a mental health problem where it makes you struggle for a few months, but it's not like a mental disorder yet, or whether you actually immediately develop a mental disorder. Okay, it depends. Everyone is different, and mental health, again, plays out differently in different individuals. Okay, the last thing that we're looking at here is mental disorder. Okay, and we've got a picture of an iPad here because that's the memory tip that we use to remember the characteristics of a mental disorder. It's important for you guys to know characteristics of a mental disorder, because if we give you like a scenario, okay, in a SAC, and we tell you, we ask you, we give you a scenario or a case study, and we say, okay, to what extent is Jennifer experiencing a mental disorder? Or do you think Jennifer is experiencing a mental disorder? Justify your response. So then you need to go back into that scenario and look at, okay, is she experiencing an impairment in her daily life? Is she experiencing a lot of personal distress? And remember, distress from chapter 3 is the negative psychological response to stress that makes you feel sad or frustrated or upset. Okay, atypical thoughts, feelings, and behavior. If you remember from last year, okay, atypical is the opposite of typical. Atypical means thoughts, feelings, and behaviors that are not typical for you as a person. So if you're always coming into class happy and, ready to do your work, and one day you come into class and it looks like you're not motivated, you haven't brought your things, that is atypical behavior for you because it's not the usual, it's not the norm, okay? And as well as dysfunction. Dysfunction means that you're not able to function normally, okay? For example, you might go days without getting out of bed. You might not actually have a shower, okay, just because you feel so demotivated with your life, okay? And generally people who have mental disorders like depression, schizophrenia, specific phobia, show a level of dysfunction, okay? And dysfunction is one of those characteristics that determine whether you've got a mental disorder or not. You might stop showing up to school, stop showing up to work, not meet up with your friends. Those are all examples of dysfunction, which is the opposite of a normal functioning human being, okay? That's the idea. So mental health problem, and mental disorder, those are our three mental health states, okay? And it's very important for you to remember what they are. So if we look at mental disorder, okay, sometimes in the VCA exams or past resources, VCA refers to mental disorder as a mental health disorder. That's the same thing, okay? As long as it's got mental at the front of it and disorder at the end, it's still the same word. Mental disorder, mental health disorder are the same thing. Even the word mental illness, VCA doesn't use this as much, but you might see it in other resources. Mental illness also means mental disorder. We don't use that terminology anymore though, because mental illness doesn't talk about the disordered effect that mental disorders can have on a person. Okay, so that's the main three differences, or the main three mental states there. Okay, these are some more characteristics just so you can get a better understanding of what a mentally healthy person looks like, what a person with a mental health problem looks like, what a person with a mental disorder looks like. This is an excellent table taken from the old Jacaranda textbook. We don't use that anymore. Obviously, we use a draw learner, but this one is pretty detailed for you to have an understanding of all the different things you might look out for in a scenario that might qualify a person as being in one mental state rather than the other. Okay, so that's the basic idea there. So you can have a look at that just to get an understanding there. You don't have to memorize the whole thing, but it's more for your understanding. Okay, then we look at this idea that mental health is a product of internal and external factors. So that basically means that your mental health is dependent on, factors like internal factors. And we say internal factors are basically factors coming from inside of yourself. Okay, so basically biological factors like your DNA, your genetics, okay, hormones. We know hormones are released differently across people. Okay, the timing of hormone release is different. Some people have hormonal deficiencies where they don't have enough of a certain hormone being released. So that's all internal. Whether you're male or female by birth, okay, immune system response, that can also have an effect because some people have strong immune systems, other people's immune systems are weaker, as well as brain functioning. Okay, all of these things are internal factors. When we're talking about internal factors with reference to the biopsychosocial model, which we learned about last year as well, but I'll explain it again. Internal factors are the bio factors in that model, or the biological factors, and the psychological factors. These are factors that all stem from inside the person or from within a person. So psychological factors include things like negative or positive thought patterns, personality traits, coping skills for stress, the attitudes that you have. Okay, all of those things can influence, your mental health then. When we're talking about external factors, we're talking about factors that come from your surrounding environment, okay? From the world around you, in other words. So whatever world or community or society you come from, basically those societies have external factors. And examples of that include what kind of friend networks you have, okay? The culture you come from, the kind of income you have, or the income that your workplace gives you. Education, whether you have access to proper schools and universities to get educated. Employment, which basically means, are there job opportunities where you live? Lifestyle, okay, which again, sometimes we can say maybe we can influence our lifestyle, but actually sometimes we have no choice. For example, if you grow up in a low socioeconomic household where there's not a lot of income, you can't just go out and buy, a lot of fresh fruit and vegetables because you find that they're quite expensive. So your parents might actually just buy a Macca's box on the way home. Be like, okay, guys, here's dinner. So sometimes your lifestyle is not just in your control. Social support is also a big one. Family, okay, family plays a big role in your mental health, okay, and that's an external factor. We can't always control that. Peer groups, as well as access to healthcare. All of these factors are external because they come from the world around you. You don't have control. Okay, that's the main thing to remember. And in terms of the biopsychosocial framework, external factors are your social factors. Okay, so remember, your biological and psychological factors form your internal factors, and your social factors form your external factors. Okay, this is important because in a scenario, if I've given you a case study, or in the exam, if you've gotten a case study and then it says outline the internal and external factors influencing Jennifer's mental health in this scenario or in this situation, you need to be able to see which factors she's able to control that come from within herself, and then describe those as the internal factors, and which factors are, rather than her acting on those factors are acting on her. So which factors are coming from the surrounding environment where she doesn't have as much control. And if you don't classify them correctly in your answer, you're obviously going to lose marks there. So that's why you have to be careful. Alrighty, so I think the next slide I've already explained in the previous slide, linked it back to the biopsychosocial model. But last year, if you remember, we looked at something called the biopsychosocial model. We are going to come across this again when we do chapter 13, which is specific phobia. We're going to apply the biopsychosocial model to specific phobia. But for now, we're just looking at the biopsychosocial model as a model or a framework that gives a holistic approach. Holistic meaning whole, okay? Whole or complete. It's a whole or complete approach because rather than just looking at the fact that, oh, this person's dad had depression, so he's genetically predisposed to get it, you look at other factors as well. You look at, okay, this guy's dad has depression, but this guy also doesn't have really good coping skills for stress, which means that when hard times come along, he breaks down, he can't cope. Okay. On top of that, this guy also doesn't have a lot of social support. He's kind of closed off from all his friends and his social support network. So when he is stressed, he doesn't have anyone to talk about it with. Okay. So rather than looking at just one factor, which is the genetics, you're actually looking at his coping skills, which is a psychological factor. And you're also looking at his level of social support that he has, which is a social factor. Okay. So that's the basic idea there. So that's why the biopsychosocial model is a holistic approach, okay? It looks at how biological, psychological, and social factors combine and interact to influence a person's mental health. And we can even apply the biopsychosocial model to physical disorders as well, but we don't really do that because we don't study many physical disorders, okay? But we will be studying the mental disorder of specific phobia in chapter 13, and we will be applying this model again to that disorder. Okay, so that's the biopsychosocial model for you. Just learn maybe like 2 examples of each of these factors. So 2 examples of biological factors, 2 for psychological and 2 for social. That should be enough. Have an overall broad understanding of what each one is and what each one could be, because you never know what you're going to get in a scenario. Okay. So these are some more factors and examples. I'm not going to go through them too much. We already know biological factors are relevant to your body, okay, and your physical functioning, and we know that they're not under our control. We can't control our DNA, for example. Psychological factors are basically factors relating to your mental and cognitive processes, like the way you think, the way you reason, the way you make decisions, the way you cope with stress. All that stuff comes under psychological. And social, again, is how we interact with others, the relationships we have, the structure or the dynamics of the society we live in. All of those things can influence. So remember, these 2 are our internal factors, and the social factor by itself is the external factor. Okay, so just make sure you remember that classification there. All right, in the next spread, we're looking at the characteristics of a mentally healthy person. So these are 3 VCAR approved, or VCAR, like they've put this in the study design, that these are the 3 specific characteristics that you need to know in depth about a mentally healthy person, or about what a mentally healthy person looks like. Okay, so there are 3 here. The first one is called high levels of functioning. The second one is called social and emotional well-being, and the third one is called resilience to life stresses. Okay, these are the 3 that are specifically named in our study design. So because these are specifically named in the study design, these are key terminology or key language related to this spread or to this outcome. So that means you need to name these exactly as they are. In the SAC or in the exam, if someone in the scenario looks like they have high levels of functioning and you just say good functioning, you're not going to get the full mark for that because you haven't mentioned the key word, which is high levels of functioning. So think of this as similar to the keywords we did in Unit 3, like unconditioned stimulus, unconditioned response. You can't change those. You have to write them as they are. So the same applies for this topic as well. With resilience though, if you just write resilience, that's okay. But I think just try to make your keywords always exact. Just get into the habit of doing that. Okay, so a person with high levels of functioning basically is a person who is able to act independently. Okay, there are two main keywords in this. They're independent people, and they can do whatever they put their mind to, or they can at least try their best to do whatever they put their mind to. Okay, people with high levels of functioning have positive impacts, not just because they're independent and they do what they put their mind to, but because they also have higher rates of participation in extracurricular activities. For example, they do things that benefit them or benefit others outside of their normal place of work. So if you come to school, for example, and you are doing other things as well, like you're doing extracurricular activity like sports, you're doing maybe debating, maybe you're a part of some clubs at lunchtime, all of those things are allowing you to have a higher level of functioning, okay? Also, people with high levels of functioning have more social support, and they allow themselves and allow people to come into their life, which is why they've got more social support. Okay, social support doesn't just come to you. You have to like grow it. Okay, you have to put time into it and invest your effort into it. Okay, and people with high levels of functioning know how important it is, so they allow themselves to have that social support. They set goals. People who have high levels of functioning, who are mentally healthy, set goals and they try their best to achieve them. And because they set their goals properly, they usually do achieve those goals as well. They think clearly and rationally. They don't jump to decisions. So they usually take their time. They think about it. They regulate their emotions well, which means they've got good control over their emotions. Okay, they don't snap at people. They try to understand what another person is going through before just showing an emotional response. And as we said before, independence is a big theme of a person with high levels of functioning, so they can look after themselves independently as well. Now, we've got two types of behavior that can influence a person's level of functioning. The first one is called adaptive behavior. Remember, adaptive means helpful. Adaptive means useful. Okay, if you're able to adapt to your environment, it means that you're able to adjust to your environment, and that's always a good thing. Okay, so adaptive behavior is good behavior. Okay, if you've got adaptive behavior, the more adaptive behavior you show, the more likely you are to have high levels of functioning. Okay, maladaptive behavior, on the other hand, is behavior that's dysfunctional in nature. Okay, it's the opposite of adaptive, and it's in red font because maladaptive behavior is not that great for us. It's actually quite bad. It stops us from achieving a high level of functioning. Okay, so people who have low levels of functioning tend to have maladaptive behavior or show maladaptive behavior more so, but people who have high levels of functioning tend to show more adaptive behaviors. Okay, so just remember that relationship there. Okay, the next one we're looking at is social and emotional well-being. So social well-being is about our ability to form healthy relationships with others. So it's about relationships, and it's also about interactions. Okay, so it's about your healthy relationships with others, and it's also about being able to communicate with others. Okay, you might have learned about this in other subjects like health as well, for example. Emotional well-being is about your ability to express your emotions appropriately. Like, for example, you don't just go to a funeral and start laughing because that's not appropriate. Okay, regulate, manage, and control emotions. So you don't just have fits of rage or just burst out in anger or burst out crying when someone tries to ask you about something. You are able to control your emotions. Okay, so people who have high levels of social and emotional well-being, they tend to have more stable health. And there's a number of reasons for this. Some reasons are that they have better relationships with others, which influences their mental health. They have a bunch of people that they can talk about their concerns or worries with. And obviously with those people, they can also seek advice. Okay. When we talk about the support network, they also have a wider support network. It's not just about having people around you to talk about concerns or worries with, but actual assistance as well. And in chapter 14, we'll look at the different types of support a group of people like this can give us. Okay, they can even give us support in terms of money. If we're low, if we can't pay the rent, they can give us a loan, for example. They can drive us somewhere if our car's broken. And that can actually help to reduce our stress depending on what the stressor is. Okay, and when you've got a group of people who support you and you support them, you feel more self-assured about yourself and more confident. Okay, so that's another way in which mental health can be benefited. So the next thing that we're looking at is this slide that basically looks at the different examples of social and emotional well-being. So you don't have to know all the different characteristics or all the different examples, but just have a read of this and have a broad understanding, okay? A lot of this is kind of common sense as well, but it's just for you to have the broadest understanding you can have of these concepts, because as I said before, we never ever really know what's going to come in our scenario. Okay, scenarios don't always look the same. They've got different characteristics. The person is going through different events. So it's always important to have a really broad understanding of what constitutes social well-being and what characteristics constitute emotional well-being. Okay, so just have a read of that and have a basic understanding there. The last characteristic that we look at in terms of characteristics of mentally healthy people is resilience. Okay, resilience is a word that we'll again look at in chapter 14. But resilience is basically this idea that you can bounce back. So in the case of hardship, or if you're going through a tough time in your life, or you've experienced some kind of difficulty, do you bend or do you break? Generally, we say people who bend are people who are resilient. Okay, what that means is that they don't break in the face of difficulty, they don't break in the face of hardship, but they try their very, very best to cope with that hardship. They try their best to adjust their life and adapt to that hardship. Okay, and when they do that, they actually are able to weather themselves through the storm, get through the storm, and come to the sunlight when there's a restored positive mental functioning. Okay. And resilience is the quality that people show when they bounce back. So you might have heard of someone who's, been kidnapped and they were tortured, and then they come back to normal life. And within a few months, they're trying their best to find a new job. They're trying their best to, get into contact with their old friends. They're trying their best to do something for the community. Those are people that show high resilience. They went through so much in their life, but they're able to bounce back from what they went through. They're able to come back to a state that allows them to, again, work towards a positive state of mental functioning, okay, or some kind of a normal mental health, okay, given what they have gone through. But remember, it's not just about, really big traumatic events like that. All of us can experience hardships, whether that's not doing well in a SAC, whether that's getting into a fight with your partner or your friend, okay? It doesn't have to be very traumatic, extreme events that we're talking about here, okay? Any hardship or any difficulty can be responded to with resilience. And these are some reasons why people who are more resilient tend to have better mental health. Okay, I already talked about the fact that people who are resilient tend to adjust to their stressor. They accept it and they try their best to work through it. Or they go the extra step and they actually overcome the stressor. They don't just wait for the storm to pass, they do active things in order for the storm to pass. Okay, so basically they fix the issue themselves. People who show resilience or who have high resilience tend to be more satisfied with their life. They know that they are in control, that they have higher self-efficacy, as in they're the kind of people that are like, okay, I'm in this issue now. What can I do to get out of it? They put the onus on themselves rather than blaming the society around them. Okay, they take personal duty for getting out of the situations that they're in. Okay, they work towards their goals actively. They're more optimistic. And that probably explains why they tend to be like looking on the bright side rather than being, down in the dumps. They have more hope for the future as well because of that optimism. And they generally tend to be more flexible and realistic. So when a stressor comes into their life, maybe if they fail a SAC, for example, they're not like, oh my God, I failed the SAC, my ATAR's down the drain, I'm going to become, I'm not going to have a job, I'm going to be homeless, blah, blah, blah. They don't think like that. They think in a realistic way, like, okay, I failed this SAC, but let's see how much it contributes towards the end of year score. Let's see what I can do to do better on the next SAC. Let's ask the teacher for where I can improve. So they are more flexible and logical in the way that they think about stress. Okay. And remember, resilience is a protective factor. It protects us against developing mental health issues. If we already have a mental disorder, trying to develop resilience can actually decrease the intensity of that mental disorder as well. Okay, now we're again going to cover resilience as a topic once more in chapter 14. So this isn't the last that you've seen of resilience or the last that you've seen of the biopsychosocial model. We will be going through those once more in the later chapters. Okay, guys, this is a summary of social and emotional well-being, as well as resilience and high levels of functioning, mainly for those of you who maybe can't be bothered to go through these slides, maybe the time before the SAC or before the exam. At least understand this table. If you understand this table, you will have a basic idea. Okay. And this is just a useful tip from your book, just telling you the importance of reading the particular scenario carefully. Because some characteristics, like, for example, communication skills or being able to communicate well with others can be, for example, seen as a source of social well-being, as well as a high level of functioning. So sometimes you've got one characteristic that applies to two or more of these headings. Okay, when that happens, it's important for you to read the scenario, to reread the scenario, and figure out which characteristics are most relevant in that scenario, or which characteristic which heading that specific characteristic should go through. So it's always a matter of reading the scenario really well. Okay. All right, and the last spread, guys, we're just looking at two ethical principles, which are basically informed consent procedures and placebo treatments. And we're looking at these specifically with reference to patients who are in mental health research. Okay, this is really important for us to remember this idea. When we're looking at these two ethical principles or ethical issues, we're not looking at these ethical issues in the context of normal, mentally healthy, not normal, but mentally healthy individuals. We're talking about this in reference to mental health research. When we do mental health research on something like depression or schizophrenia or phobia, we can't have participants who are mentally healthy. We need to be recruiting participants who have those mental health issues, okay, who have those mental disorders that we are studying. For this reason, have those mental disorders. Okay, for this reason, we are using patients as in people who have these mental disorders. We're using patients who have depression. We're using patients who have specific phobia, okay, who actually live with those conditions in their real life. So this spread basically looks at when we try to involve patients who have mental disorders themselves in mental health research or experiments or research studies, what are the ethical issues that come up as a result of using those people compared to using mentally healthy individuals? And there are two main ones we're going to learn about. The first one is informed consent, okay? And the second one is the use of placebo treatments, okay? I want you to look at this comic here, and I'll actually come back to this comic. This is actually related to informed consent, and use of placebo treatments is the other one we'll look at. The main idea you guys need to keep linking back to with these two ethical implications is that whenever we're doing research with any participant, whether they're mentally healthy or not, the main kind of motto we have in our mind is do no harm, okay? Do no harm. And the reason that we're studying these two topics is to understand that we don't want to do harm, especially with patients who are as vulnerable as people with mental health issues, okay? So that's the basic idea. So just to quickly recap, informed consent, we've learned about this in research methods, but informed consent is just the experimenter's way of getting information from the participants about whether they want to participate in the study or not, okay? A lot of the time, informed consent is given because participants have a chance to read the details that are on the form there, and the details include all of these tick dot points, okay? As well as decide to participate. So if I read through these details and I'm like, okay, it looks good, and then there's something in there about, let's say, the risks that are involved in the study, I might then be like, okay, you know what, actually, I don't want to participate, and I don't give my consent. I don't sign on the dotted line, okay? The main purpose of informed consent is to make sure that the participants or the patient's choice to participate is voluntary, which means it's their own choice rather than something that's forced, okay? And that it's not just consent, right? It's informed consent. So the informed or the information is all of this, okay? The nature, purpose of the study, risks involved. It's every participant's right to know what they're getting themselves into before they sign on that dotted line, okay? So that's what informed consent is. Now, if we're going to look at informed consent in mental health research, we have to remember that there are ethical implications for patients involved. In a nutshell, people who do not have stable mental health or who have mental disorders like depression, they have cognitive impairments. What that means is they don't think, they don't feel, they don't process emotion, they don't process knowledge in the same way that a mentally healthy person would. Remember, we said that people who are mentally healthy generally tend to think clearly. They make better decisions. They don't rush into things. People with mental disorders are the opposite. They don't think clearly. They're not able to make good decisions half the time. They don't have rational ways of thinking. They don't use logic all the time. And it's not really their fault. It's actually a result of having the mental disorder that they have. Mental disorders, again, can stuff up our cognitive functioning, okay? It can affect our cognitive functioning. So when you're a researcher and you're asking your patient who's maybe got something like, let's say, depression, and he's already, not thinking very clearly in his usual life, and you ask him, okay, this is the deal, what therapy would you prefer? And it's like all mixed up, or it's not clear, it's all jumbled up. He might just say yes to impress you or to please you, as, yeah, I want therapy B, but he might not actually understand what he's getting himself into, okay, because of the cognitive impairment that comes from his depression. So because of that, it's really important for people around this patient to be able to be there with them when they're giving the informed consent. So we can make sure that that informed consent is not only accurate, but also genuine, okay? That the person is not impeded by things like decreased memory, by inability to make decisions. In some cases, people with mental disorders have such severe cognitive impairment that they can't actually consent for the study on their behalf. They have to sit with their psychologist over a few sessions. The psychologist has to explain it to them slowly, what they're getting themselves into. And then finally, it's the psychologist or the mental health professional that actually gives that consent, or the parent of the patient who gives the consent, okay, or the guardian of the person that gives the consent, okay. Sometimes there's no way for the actual patient themselves to give the consent because of that cognitive impairment that they have, okay. So that's to do with the ethical implications of, and these 2 points here are extremely important. The previous slide is not as important. That's just recapping what informed consent is for those of you who might have forgotten. This is extremely, extremely important, okay? We'll only ever ask you for the ethical implications or the link back to why informed consent can be an ethical issue in mental health research. So that's the main idea. The next thing that we look at is placebo treatments. Again, this is just an introductory slide into what placebos are, okay. The main idea you need to take from this slide is that placebo treatments are not real treatments. They're just kind of like fake, it's a fake drug, okay. And so generally in any independent groups design study, there are 2 groups, if you remember. One is the experimental group. They receive the IV, or they receive the experimental treatment or medication. The control group, they do not receive the IV, but instead they actually receive a fake drug or an inactive substance called a placebo, okay? These are the group of people that we're concerned with. These are the people who we think can be ethically disadvantaged, okay? And these are the people that we focus on with this dot point here, okay? This is a nice way to summarize placebos. Placebos are basically this idea that if you believe it will affect you, it will. If you don't believe it will affect you, it won't, okay? So that's the basic idea behind placebo treatments. And it's always the control group in any study that gets the placebo treatment. So any mental health patient in the experimental group in the context of this topic is fine. They won't be affected, okay? It's the control group participants who will be affected. I'll explain why that is on the next slide. Okay, so when we look at the ethical implications of placebo treatments, what we need to remember is this, okay, and I'm going to try to make this as clear as possible. If you've got a study and you've got a researcher, let's say they're the experimenter, and then the experimenter decides to do a study on a new antidepressant medication, okay, new antidepressant medication, he obviously needs patients who already have depression, because you can't give an antidepressant medication to someone who's healthy. It's not going to have an effect. So he's getting about 10 participants, okay, 10p, all of them who have depression, okay? All of those participants have depression, okay? He wants there to be equal participants in each group. So he says, okay, let's put 5 participants in the experimental group, e.g., and then we've obviously only got 5 participants left, so there'll be 5 participants in the control group. Okay, these 5 participants in the experimental group, they're already taking antidepressants on their own. It's probably not the same brand as the new one, but they're already taking their own antidepressants. The experimenter tells them, you know what, you continue taking your antidepressants, but also take this new one in conjunction to that. So you can still keep your antidepressants, but take the new one as well. So they're still in some way or the other taking an antidepressant medication. They're not completely stopping that. The control group participants, however, who have depression, they will need to stop taking all antidepressants. And this is where the issue comes up. If you're taking 5 people in your control group who you know, all of these people have depression, okay, and you tell them, listen, I need you to stop taking your current antidepressant medication because if you continue taking that, my results are going to get stuffed up. And you're asking them to do that, that can actually influence their health and well-being. Now, this is not illegal, by the way. It's actually completely normal and common to use placebo treatments in mental health research, to tell the participants in the control group that, hey, because we're giving you a placebo, we need you to stop taking your normal or your usual antidepressants. Okay, it's completely normal to ask them to do that, or completely typical. Okay, the main issue that's going to come out of that is that the minute these guys stop taking, and that's where the stop comes from, the minute these guys stop taking their antidepressants and start taking the placebo, what did we say about the placebo? It's a fake treatment. It doesn't have any active substance. It's completely just like a white pill. It's got nothing in it. So these guys start taking the placebo, start thinking in their brain that, oh, this will make me feel better. But in actual fact, inside their brain, there's no improvement there. Okay. And after some time, they might keep kidding themselves that, oh, yeah, I'm feeling better. But actually, their mental health is taking a big decline. And there's a lot of hormonal and a lot of neurotransmitter imbalance that's starting to build up in their brain because they stopped taking the active drug and started taking a fake drug. So how can obviously researchers look after mental health patients and prevent this from happening? What they can do is that they can ensure that the participants that are in their study actually are not like severe cases. Okay, I can't take a participant or a patient in my study and put them in the control group if they've had multiple suicidal tendencies in the past 2 weeks, if they are literally dependent on the antidepressant medication to live. Okay, in the sense that if they were to stop their medication, they would be completely off the rails. They wouldn't be able to function. I can't use people like that. What I can do is, as an experimenter, is I can take participants who are very mild, maybe in the beginning stages of depression, whose symptoms are still not that severe, and I can use them, but I can't use people who are already at an extreme or intense or severe level of depression there. Okay, because by telling them to stop their active medication, I could be putting their life at risk and their well-being at risk. Okay, we know some people are dependent on these medications to be as close to a functioning person as they can. Okay, and we can't just say you got to stop taking this and start taking a fake treatment, because the fake treatment doesn't have that 20 milligrams of antidepressant ingredient. Okay, it's a fake drug. It doesn't have any active substance. And so it can actually be harmful for patients if they were to take the placebo, because their mental health condition could actually become worse in the absence or as a result of them stopping their actual medication. And remember, guys, like I said before, this is only an issue if you're a mental health patient who's in the control group. Okay, this is not an issue at all for a participant who's in an experimental group, because they are not asked to stop their active medication, because they're the experimental group. They continue with the experimental treatment, but it's the control group who's not supposed to have the IV or who's not supposed to have the experimental treatment. So they're the ones that inevitably end up having to take the placebo. Okay, so that's the basic idea. So these are the risks that I just talked about. And the only benefit is that it's better to use a human participant when we're talking about placebos, because unlike using an animal for the placebo group or for the control group, you have a more equal playing field. Okay, if you've got humans in your experimental group, it's better to compare them with actual humans rather than other like animals or other things like that. Okay, so that means your results will be more likely to be generalized. So you can see obviously the risks outweigh the benefits here. Okay, cool. There's a question. Mrs. The mental health getting better when they believe. Look, for some patients in the beginning, when they take the placebo, they feel like their mental health is getting better. But as we know, there's only a certain limit to which you can kind of deceive yourself that you're feeling better. After a while, when they're not taking the antidepressant, the actual medication, inside their brain, there starts to be a severe neurotransmitter disbalance or imbalance, sorry. And that starts to make them actually, without them realizing, it starts to make them more unstable. They might get more jittery. They might get more on edge, okay? And no amount of fooling yourself otherwise is going to actually fix that. So initially, they might feel like their mental health is getting better, but in the long term, it's not good to have them like that. Okay, yeah, that's it. Okay, guys, so that's chapter 11 done. We just finished on the dot. Another question, can a placebo just be a different medicine? No, a placebo has to be inactive substance. So we can't have another brand of antidepressants because remember, guys, in the control group, that's our basis for comparison. Okay, so we need to have, for example, if I'm doing an experiment on the effect of sports drinks on athletic performance, the experimental group would be drinking the sports drink, let's say Gatorade, but that doesn't mean the control group can just drink Powerade or can just drink a Red Bull because it'd still have an effect there. So what would have to happen is the experimental group has to drink the Gatorade and the control group just drinks like plain water or just drinks nothing extra, okay? So it has to be a substance that is a completely inactive substance that's not known to have any effect. That's the idea, okay? Alrighty. Any other questions, guys, about anything that we've done so far in chapter 11? No? Okay, look, I know that we covered 3 spreads in one go, but again, this chapter isn't too long, so that's why I wanted to just get it done in one go there. Okay, so you've got the whole weekend, and I'm going to give you Tuesday as well to finish off your questions for chapter 11. Just make sure that you do finish that so it doesn't pile up. So what I'll do is I'll just stop the recording here.